Hi friends, so we've discussed some very important GI tract and hepatobiliary images and conditions. Now another important high yield topic for your Ini-Cet exams is vascular imaging. So this will include peripheral vascular disease, aortic conditions, aortic aneurysms, dissections, pulmonary embolism. So these are also favorite topics asked very commonly in your Ini-Cet exams. So let us quickly go through a few important questions and images. So see, a patient presents with bluish discoloration of the toe, intermittent claudication. So probably what you are looking at is peripheral vascular disease. Which of the following will be the next appropriate investigation? So they have not asked you investigation of choice. They have asked you, you suspect peripheral vascular disease. What is the next investigation that you do? Remember, for all vascular abnormalities in the body, we can actually define what would be the first investigation, investigation of choice and gold standard. The first investigation for any vascular abnormality is usually, remember, a duplex scan. Why is it called a duplex? It is an ultrasound scan because it includes basic B mode ultrasound evaluation plus a Doppler evaluation. So because it is a combination of B mode ultrasound and a Doppler, it is what is called as a duplex scan. Okay, now let us look at how we can define the various sequence of tests that is to be done for vascular disorders. So remember this concept. If they ask you for any vascular abnormality, and we are going to apply this rule as we go ahead, what would be the first or initial investigation or the next investigation as was asked in this particular question? It would always be a duplex scan. So duplex scan is a combination of USG plus color Doppler, power Doppler. So USG plus Doppler. If they ask you in the same question that they had asked, if they would have asked what is the investigation of choice, then remember, in most vascular conditions the investigation of choice is either CECT, or the option can also be CT angiography, or it can sometimes also be MR angiography. It is very difficult even today to choose between CT and MR angio because both of them are excellent techniques, both of them have their pros and cons, but what is more commonly used, which is quicker, more readily done, is a contrast enhanced CT or CT angiography. If a patient is having renal failure, contrast cannot be injected, a follow-up studies to be done, elderly patients, then MRI is preferred, otherwise CT is the investigation of choice. For any vascular abnormality in the body, if they ask you what is the gold standard technique, then remember it is always invasive catheter angiography. It is always invasive catheter angiography. Okay, so this is the rule. Let us apply it for a few conditions. So see, if they ask you for peripheral vascular disease, initial investigation, yes, it will be duplex scan. Investigation of choice will be CCT or CT angio. Gold standard would be invasive catheter angiography. Okay, this holds true. Investigation of or investigations to be done for suspected renal artery stenosis. Initial investigation is what? For any vascular abnormality, duplex scan. So in evaluation of the kidney, it is called as renal artery Doppler. That is nothing but a duplex scan, that is a B mode evaluation of the kidney along with Doppler. So that is renal artery Doppler. Investigation of choice is CT angio or MR angio. CT angio is usually preferred. Gold standard is going to be what? Gold standard is going to be invasive catheter angiography, right? Now if they specifically ask you the investigation that will show you the functional significance of stenosis, so functional significance of stenosis, if they ask you this specific question with the terms functional significance of stenosis, then it will be captopril DTPA scan. Captopril DTPA scan shows the functional significance of stenosis. That would be the answer in that particular case. Okay, now venous abnormalities, it is an exception. right? Whatever we have seen until now, they are usually vascular arterial abnormalities. For venous abnormalities like varicose veins, say deep venous thrombosis, if they ask you investigation of choice, it will be a duplex scan, that is USG plus Doppler. And if they ask you what is gold standard, that remains the same. Gold standard for any vascular abnormality, arterial or venous, is going to be invasive catheter angiography. Alright, so this is about the various conditions, various investigations used for various vascular abnormalities. Now look at this question, a very peculiar vascular abnormality. A known hypertensive patient, hypertension is a predisposing factor, most important predisposing factor for this particular abnormality, underwent a CECT which revealed this finding. What is this finding? Look at the aorta. In the aorta, can you see a septum here? What is this? This septum is nothing but an intimal flap. And when you see an intimal flap within the aortic lumen, it suggests a diagnosis of aortic dissection. What is this aorta? Is it the thoracic aorta or the abdominal aorta? This is abdominal aorta. So what is this diagnosis? This diagnosis is abdominal aortic dissection. That is going to be the diagnosis here, right? Now, if they ask you what is going to be the investigation of choice for aortic dissection, see, vascular abnormality, what is the investigation of choice? It is always a CT angio or a MR angio. CT angio is usually preferred. If they ask you what is going to be the gold standard, we have already studied this, right? Isn't it? What is the gold standard for any vascular abnormality? Yes, it is going to be invasive catheter angiography, right? So this is about aortic dissection investigations. Now there is a classification system which is used. We are going to discuss that. What is this? This is DBK and Stanford classification systems. We are going to discuss that. And surgery is required. Remember this, your examiner may give you the extent of dissection and then ask you what could be the treatment. Remember this concept, surgery is required always when the ascending aorta is involved. Whenever the ascending aorta is involved, right, the treatment is going to be surgical. If the ascending aorta is not involved, only the descending aorta is involved or the abdominal aorta is involved, then the management can be conservative. Alright, so now let us look at the classification system. It can be DBK or Stanford. Let us first focus on DBK. If both the ascending and descending aorta is involved, it is called DBK 1. If only ascending aorta is involved, it is called DBK 2. If only descending aorta is involved, it is called DBK 3. DBK 1 and 2 together are called Stanford A and DBK 3 is Stanford B. This makes more sense because I just told you whenever the ascending aorta is involved, then the management is always going to be surgical. Whereas if the ascending aorta is not involved, as in this case, the management can be conservative. Okay, so that is about DBK and Stanford classification system. Various signs have been described. If you look at the intimal flap here, the intimal flap towards the edge is forming a beak-like appearance. So this is called as the beak sign of aortic dissection, right? Whereas sometimes the shreds of media, as you can see, the intimal flap is not straight here. There are some shreds of the media projecting into the false lumen. The larger lumen is usually the false lumen. The smaller lumen is usually the true lumen of the vessel. Remember, these shreds of media that project into the false lumen look like a cobweb. So this is called as the cobweb sign of aortic dissection. So beak sign, cobweb sign, these are signs of aortic dissection. Now we come to aortic aneurysm. There is no intimal flap, but the aortic diameter is focally increased. So what is the overall most common site of aneurysm? The most common site overall is usually of aortic aneurysm is usually involving the abdominal aorta. It is usually infrarenal, that is beyond the origin of the renal arteries. That is the overall most common site of aortic aneurysm. Most common site of thoracic aortic aneurysm, right, is ascending aorta, right? How do you diagnose aortic aneurysm, you say that a particular part of the aorta is more than 50% dilated, then it's pre-dilatation lumen, then that is aortic aneurysm. But if you use absolute cutoffs, then you can say that for the ascending aortic aneurysm, the cutoff is more than 5 centimeter diameter of the aorta in the ascending aorta is aneurysm. For the descending thoracic aorta, a diameter more than 4 centimeter is considered to be aortic aneurysm, and for the abdominal aorta, a diameter more than 3 centimeter is considered to be aneurysm. So these are absolute threshold values. Okay. Now very important, your examiner may ask you what are the signs of impending aneurysm rupture, because that is where the management becomes very emergency, right? It becomes an emergent management in those cases. One, if you see a rapid increase in the size, so a rapid increase in size, how much? Say more than 10 millimeters per year, or an absolute size of say more than 5.5 to 6 centimeters, that is the diameter of the aneurysm. If you see a hyper attenuating crescent, if you see a slightly bright appearing crescent in the wall of the aneurysm, then this is what is called as the crescent sign. It suggests that the blood is actually insinuating into the vascular wall and it may rupture any moment, right? So this crescent sign is a sign of impending rupture. Next, an aorta must always be round in shape like this, see, but if the aorta loses this round shape and drapes around the adjacent vertebra like this, then it is called as a draped aorta sign. See, the aorta has literally draped around the adjacent vertebra. This is what is called as the draped aorta sign. It has lost its round shape, draping around the vertebral body. This is also a sign of impending rupture. Apart from that, if you see fat stranding around the aorta, if you see the contrast in the lumen actually coming out, then that is absolute rupture, direct evidence of rupture. So all these are signs of impending rupture of aneurysm. This is a topic on which questions are very highly likely to be asked. Yes. Now this is a sign suggestive of turbulence. This is what is called as the yin-yang sign. Yin-yang sign is based on Chinese mythology, there being a positive and negative aspect balancing each other in each particular situation. That is what the philosophical concept is. Basically, because of turbulence on color Doppler, you see a red area, you see a blue area within an aneurysm. That is what is called yin-yang sign. Traditionally, it has been described in pseudo aneurysms, right? Though traditionally they have been described in pseudo aneurysms, remember they are also seen in true aneurysms. Rather, what the yin-yang sign basically shows you is a turbulence of the blood flow, and that is what is creating the red and blue appearance on color Doppler. Yes, so this is what is called as yin-yang sign. Now look at this typical clincher. A 35-year-old young male presents with 4 weeks of immobilization for fracture femur. So because there is immobilization, there is a deep venous thrombosis. This thrombus has dislodged from the lower limb veins, went into the right side of the heart, went into the pulmonary artery and gets stuck within the pulmonary artery. So the patient has sudden onset chest pain and hemoptysis. ECG shows a very clincher S1Q3 T3 pattern. You look at the ascending aorta, normal, descending aorta, normal. You see the main pulmonary artery is normal, dividing into right and left parts. Look within the right pulmonary artery, you see this filling defect. This is nothing but the thrombus in the main right pulmonary artery. So when a thrombus is stuck or an embolus is stuck within the pulmonary artery, it is what? It is pulmonary embolism. So this is a very classical history clincher of pulmonary embolism. Yes. Now what is the role of various imaging modalities in pulmonary embolism? See, a D-dimer test is usually done as a screening test, remember, right? So it has a very high negative predictive value. That is, if the D-dimer test is normal, right, it means that the patient does not have pulmonary embolism, very high negative predictive value. So that is used as a screening test. Chest X-ray is normal in most of the cases. However, in olden days, a lot of named signs, because it was the only modality which was available, a lot of named signs have been described on a chest X-ray. We are going to discuss that very quickly. CT angio or CT pulmonary angio is considered to be the investigation of choice for pulmonary embolism imaging. ventilation perfusion scan, VQ scan, was done in the olden days. It is not commonly done now. Defects described on ventilation perfusion scan are mismatched defects. Mismatched defects on ventilation perfusion scan suggests pulmonary embolism. Invasive pulmonary angiography is considered to be the gold standard technique. So this is the role of imaging modalities in pulmonary embolism. Chest X-ray, I have said, is normal in most of the cases, but some names and signs and appearances have been described. Let us quickly look at them. If because of the embolus there is a pulmonary infarct, that pulmonary infarct looks like a wedge, that is called Hampton's hump. A wedge is triangle with its base towards the periphery and apex is towards the center, the direction from which the blood was coming, but it has been blocked because of the embolus. So this is what is called as the Hampton's hump. This is nothing but a pulmonary wedge-shaped pulmonary infarct. When this infarct begins to resolve, it resolves from the periphery towards the center like a melting ice cube. So this is what is called as a melting ice cube sign. Because there is a sudden block of a blood vessel or an artery, there is a sudden abrupt, cut off and prominence of a pulmonary vessel, that is usually the right main pulmonary artery. It is called Fleischner sign. Prominent right main pulmonary artery is called Fleischner sign. Similarly, prominence and abrupt cutoff of right descending branch of the pulmonary artery is called Pallas sign. A cutoff, an abrupt cutoff of the right descending pulmonary artery is called Chang's sign or knuckle sign. Whereas because the blood vessel has been blocked, right, the lungs distal to it are not going to receive blood supply, so there will be a focal oligemia. So this focal oligemia or decreased vascular markings in the affected portion of the lungs is what is called as the Westermarck sign. So these are various named signs that you must know. On a contrast CT, the thrombus within the artery may appear as a filling defect at the center with contrast surrounding it. This is what is called as the polo mint sign. This is what is called as the polo mint sign. Looks like a polo mint, the central filling defect of the thrombus surrounded by contrast all around it. Remember friends, confidence is silent, insecurities are loud. This is the time to abstain from, to refrain from going on to the various social media platforms. There are a lot of controversies, confusions which are often created on these platforms, and in this last crucial period of your preparation, this serves more like a distraction, an unneeded distraction, rather than being helpful at this stage. And therefore remember, I want you to keep working hard in absolute silence. That is what winners do. It is your success, it is your result, it is your rank which will make the loudest of noise and the loudest of announcement after the exams are done and the results are out. Each day, by doing these sessions, we are trying to get one step closer to that particular outcome here. So keep working hard. All the best.